Great. Thank you. Thank you very much for the invitation, and very happy to see this meeting happening. We're very excited with the progress in the SOHO, and now we have a number of regional SOHO meetings, including ones in Spain, Italy, as well as Middle East. We have one with Lebanon. Actually, the first SOHO India should be happening later this in October. Me and Dr. Jen will be going for that. And then others also. So France later this year, Dr. Gantarjan, me, Jabur will be going for that. So this is fantastic because this was the whole idea of SOHO that was developed by Dr. Kantarjan, was to spread knowledge and work with institutions all across the world. And we have Dr. Alotaibi, who was a fellow with us many years. It's very heartening to see he's doing so well and building the bridges and collaborations with the help of all his colleagues with MD Anderson. So this is fantastic. We have seen many of our fellows go and go do great things back in their home country and build the collaborations with us at MD Anderson. So very nice. And hopefully we will be in person at some point in the near future. So these are the research funding. I do a number of clinical trials, many phase 1, phase 1B, like does Dr. Bortaker, who spoke to you, as well as my consulting. So to start with, I think AML is a difficult disease. It remains a difficult disease, but we have to acknowledge there is progress. And I think a number of these drugs that have been approved as single agents will eventually have much more impact when combined. And you will hear about this in much detail with the success already occurring with combinations in ALL from Dr. Kantarjan a little bit later. There you see, for example, single agent Blina, single agent Eno, single agent Ponatinib all have, yes, some improvement, median benefit, but when you combine them, Blina, Ponatinib, mini CVD, Inotuzumab, use of CAR T and MRD, that is when these few months median survival leads to curative improvements. And I think this is what will occur now in the next 7 to 10 years in AML. So I think all of these drugs, single agent ENA, Citinib, Ivositinib, Gilteritinib, are good, but really when they're combined, I'll show you some of that early data that hopefully will mature both in single arm and planned larger registration studies. So I'm going to focus on the topic of adverse risk. And adverse risk is a very big group in AML, especially if you look at the ELN 2022, where I would say close to 40% of AML falls in the adverse risk group, because now even patients with splice mutations are considered adverse, because these are considered to be secondary AML defining mutations, includes the ASXL1, BCOR, AZH2, RUNX1, others. And then, of course, you have the traditional adverse, the deletion 7, 5, 17, TP53 mutation, inversion 3Q, and also chromosome 11 abnormalities. Now, FLT3 is not adverse, but I think it's important to talk about FLT3. It is not adverse now because of the advent of FLT3 inhibitors and the use of transplant in the frontline setting. It was adverse 15, 18 years ago when the first reports of FLT3 came out from Japan, Germany, UK, and from MD Anderson, showing that the 5-year survival in young patients with FLT3 was 20-25%. Now with the FLT3 inhibitors better, but I still think this is a group that deserves to be discussed. Now, the other big thing that we have seen and published, and also now the German cooperative group AMLSG looked at, was about time to start of treatment. And for the fellows and for the junior faculty, many of you who may have read textbooks from 8, 10 years ago, the saying is, do not let the sun set on AML. It's an emergency, acute myeloid leukemia, must rush, start treatment same day. That is no longer the paradigm. And the reason for that is twofold. One is I think we have become better at stabilizing acute leukemias, the majority of them. So if somebody's come with white count 20, 30,000, you can easily admit, give them some hydria, do some hydration, allopurinol, optimize labs, monitor closely, and there is no harm while you're waiting for the molecular information. And the second reason, of course, is exactly that, waiting for the molecular cytogenetic information. And this is important now because you can actually do things about it. There are targeted therapies, FLT3, IDH1, 2, potentially TP53 directed, and potentially MLL NPM1 directed that can actually have a big difference in response rates and improve survival. And so the paradigm today is to safely monitor and weight patients and try to get molecular information to select optimum personalized therapy rather than rushing to therapy. Now, I don't want people to go with the message that, oh, let's wait in 150,000 white count patient. Of course, there are outliers, 10% of patients who will come with very proliferative disease, very high white count, organ failure, sepsis. You cannot wait. That is okay. But for the broad 85, 90%, one can safely wait. If you feel uncomfortable, admit the patient, get the molecular information, and monitor them closely. And this was shown now in this study. If you could do this in large academic centers that are the ones that enroll on the AMLSG. They looked at more than 1,000 patients. Waiting 5 to 10 days or even 10 to 15 days in this study did not show a big difference in early mortality, in CR rates, and overall survival. I think the same study actually today will show that for those who you did not wait, the outcome may be worse because you did not pick up FLT3, you did not pick up IDH, you did not pick up TP53, and that actually will probably lead to worse outcomes. So getting molecular data is critical. Now, the goal, of course, should be to get all of this molecular data quickly within 5, maybe maximum 7 days. And I think that is something each of us as leukemia investigators has to work very closely with our heme path investigators to optimize the weight spread out. For example, at MD Anderson, we designed a two-part molecular panel. So we have a rapid MDL panel that gives us the initial 9 genes that are most actionable for treatment: FLT3, IDH1 and 2, NPM1, TP53, CHAC2, etc. And then we have the bigger 81 gene panel that comes with all the other genes that are nice for research, prognosis, retrospective analysis, the ASXL1, the B core, the GATA2, these things, but does not impact my initial treatment. And so each institution, I think, has to work with the way so that they can get this data in 6 to 7 days. Now, before I go to more targeted therapies and other approaches in high risk patients, I think it's important to note that we have not forgotten or gotten away from chemo. Maybe in 8, 10 years, I hope we will, and that is the effort with a number of those combos. But for today, there is still a role for intensive chemo. This is the most updated data from the FLAG-IDA venetoclax frontline study. There's also a parallel CLIA venetoclax frontline study ongoing. Here you see remission rates are fantastic, 90%. Most of these MRD negative, 2-year survival above 85%. This is looking quite good. And for a young patient today, and young is also subjective, that number is changing based on the availability of better therapies for older patients. But below 60, I would say today, we are still going for the majority of patients for FLAG-IDA ven. Now, of course, if the patient has a TP53 or deletion 17 or a FLT3, that will change. But for the majority who do not have a clear targetable mutation or clear adverse mutation known to be resistant to intensive ARC-based, FLAG-IDA ven or CLIA ven are our baseline standard therapy, and this is still looking good. So we're not at the point where we take a 50-year-old with the RUNX1, GATA2, ASXL1, something like this, and give him HMA ven. I've heard some investigators in the US talking about this. I don't think we have the data yet. There are randomized study actually looking at HMA ven versus intensive chemo in that specific young fit patient. If those data look like there is equivalence, then I think we can make that shift, but we are not yet comfortable because you can see the 3 to 5 year survival could be still quite high in these patients, and HMA ven may not give you the same. We don't know. In the relapse setting also, I think FLAG-IDA ven is very, very good. And the nice thing is it seems to work regardless of the underlying mutation, whether it's favorable, intermediate, adverse, except for TP53. In the TP53 mutated FLAG-IDA ven also can give you remissions, but they're very, very short-lived. Outcomes are not good. So we use it sometimes, but we're looking more for TP53 specific other therapies. But for everybody else, this is a great option in remission. That being said, it is quite myelosuppressive. So one should have a big academic center, ID, ICU support, ability to monitor counts daily, transfuse, use growth factors, use antibiotics. But that being said, for a young patient, 30, 40-year-old with relapse AML, without TP53, this is probably your best chance of getting him into remission and to transplant. And if you have a good academic support, logistical support, I think this is a great regimen to consider. So this is our approach today in the frontline setting at MD Anderson. We used a backbone of purine analog with cytarabine and idarubicin. We could have a whole lecture about why. There are many papers actually already showing that the addition of purine analog to 3 plus 7 improves both event-free overall survival. In fact, the Polish did a large randomized study of 500 patients with purine analog with 3 plus 7 versus 3 plus 7, showed event-free overall survival for all patients, especially for FLT3, and this is published in JCO. A lot of people ask me why is it not adopted. I guess people's emotions override data because the data was very clear. You don't get 500 patient randomized study showing clear benefits. So that plus, of course, there are prior studies from the MRC, Alan Burnett, from us, all showing that FLAG, IDA, or CLIA in appropriately selected patients in good academic centers with good support, always we're performing better than the traditional 3 plus 7. Now, I think we can make it even better with the addition of either targeted therapy like a gilteritinib or IDH inhibitor if you have a target, or venetoclax. We are transplanting more patients at MD Anderson today. Almost 50 to 55% of our patients below 65 are going to transplant if they're intermediate adverse. And for FLT3, we are transplanting close to 80% of our younger patients. We just reviewed this with our transplant group. So transplant is very, very much a part of the treatment paradigm. And then post-transplant, we're doing maintenance. So if you look at this and you treat myeloma, you're going to say this is looking very much like multiple myeloma. And indeed, that is true. So it's not one therapy, it's total therapy, induction, targeted therapy, transplant, maintenance, and hopefully this will improve 5 year survivals over the time. So these are the targets: FLT3, IDH, NPM1, TP53. Two of these are well validated, established, multiple FLT3 inhibitors approved, gilteritinib and midostaurin, hopefully quizartinib very soon. IDH in the US is approved for relapse. Now with the Agile study, AZA, ivosidenib approved frontline across the world, which is a great option. And then for TP53, we don't yet have breakthrough, but we are hoping CD47 antibodies will show improvement. It may not be a dramatic breakthrough, but hopefully there will be incremental progress, improvement in survival. And realistically, that is what we can hope for some of these adverse risk groups. I do not think there will be one drug that changes them overnight. It's probably going to be a stepwise incremental progress, and hopefully the CD47 and or APR will start that process. The menin inhibitors are a very effective group. I'll talk about those more when they are for the MLL rearranged NPM1 mutated. So let's talk first about a FLT3. This is, in my view, still considered not adverse, but still considered a high risk group that should be identified rapidly. It's important to note that there are differences between the FLT3 inhibitors, the type 1 and the type 2. Dr. Alotaibi, in fact, has published a very nice paper in Blood Cancer Discovery showing the resistance patterns are very different between type 1 and type 2 FLT3 inhibitors. And it's very important to know if you're dealing with an ITD alone, where type 2 inhibitor can work, quizartinib, sorafenib, or ITD and TKD or TKD alone, where you would only use a type 1 inhibitor like gilteritinib and midostaurin. Now, that being said, it doesn't mean that the type 1 inhibitors do not lead to resistance. They do. The resistance is not on target, it's off target. So with the type 1 inhibitors like gilteritinib, we and others have published that you often get other new pro-survival mutations like RAS MAP kinase, BCR-ABL. So it's not on-target resistance, off-target resistance. And that's important because maybe you can start with type 1 or type 2 and then switch to the other because the resistant patterns are quite different. I don't think these drugs compete with each other. They can be sequenced to get the optimal survival for the patient. So now looking at the midostaurin ratified data, I'm just going to show one slide. I know you're all very familiar with this. I will say in my experience and at Anderson, we're not huge fans of midostaurin. It's a multi-kinase inhibitor, never showed very potent single agent activity, almost no single agent activity actually. And it is quite difficult. Patients don't like the drug. I mean, they can tolerate it, but it's not the one they like. They has a lot of weird taste, nausea, and other issues. That being said, it met a primary endpoint, led to improved survival, did get approval, was philosophically very important to show targeted therapy works in AML. And of course, if you can give the targeted therapy, the FLT3 inhibitor midostaurin here, and take patients to transplant, you can hope for 4 and 5 year survivals in the 60-65%, which is great given that FLT3 historically had 20-25% survival in the frontline setting. So I think it's a good drug if one did not have any other options, but I do think we're looking more towards the second generation FLT3 inhibitors that were designed as FLT3 inhibitors that are very potent single agents and also combine well and often seem to be better tolerated and liked by the patients. So this brings us to the quantum first quizartinib frontline study looking at intensive chemo quizartinib versus intensive chemo placebo. Two big differences between this study and the Ratify because people tend to look at the curves and compare them, but I don't think that that is really accurate. So the one big difference is this study allowed patients 18 to 75 years of age, whereas Ratify was 18 to 60. And in fact, 40% of the patients in the Quantum First were above 60. So 40% of the population in this study was older, usually associated with more early mortality, toxicity, difficulty in tolerating therapy. Outcomes are not as good. And the second is, of course, this is only ITD. 100% were ITD, whereas in the patients who were receiving 3 plus 7 with midostaurin, 25% were TKD. TKD also tend to do better. So these are different populations. It will be good, and I hope in the final publication the data will be there for those below 60 and above 60, and then we can maybe make a more clear comparison of the below 60 patients on Quantum First that will be kind of similar to the Ratify population. One would say, well, it would have been great to randomize against midostaurin. Yes, it would have, but when the study was started, it was 2 years before anybody had seen the ratified data, and the standard of care was 3 plus 7. And of course, when the study had initiated and was locked in with the phase 3 design, it is very difficult to change it. So it was not that it was designed to not use midostaurin, even though we knew it worked. It was just a timing thing. When it started, we did not know what midostaurin was going to do. This was the overall survival endpoint was met 31.9 versus 15.1. That is good. About a 10% survival benefit around 3 years. That is quite good. But really, I think what is important is that in those who went to transplant in CR1 and received quizartinib, that's when you start seeing the really encouraging survivals at 3 years, about 70-75%. But also, I think the other is true that we know that in spite of our best efforts and in large academic centers, whatever we do, there's going to be 30 to 50% patients who cannot make it to allo transplant in first remission. And so the question comes up, well, is quizartinib giving them a benefit outside of bridging them to transplant? I think this data here suggests it is, that even in those who for some reason or the other could not proceed to allo transplant in CR1, there was a survival benefit. This is good and is a testament to the efficacy of the drug without transplant. Now, still, we would like to transplant. We want people to be on the left side curve if possible, but if they don't, still giving them quizartinib, you are benefiting the patient. Now, the other important step in the treatment of FLT3 has been maintenance. So this is the sorafenib maintenance post-transplant, showing that use of sorafenib maintenance in FLT3 mutated patients who go to transplant was associated with event-free overall survival. Two randomized phase 2 studies have shown this. This one and another one from China. We are waiting for a randomized phase 3 study of gilteritinib maintenance versus observation in patients who go to transplant. This is a large BMT-CTN 16 study led by Mark Levis. We're hoping will be positive and bring gilteritinib, which is a very, very well tolerated drug, definitely easier to tolerate than sorafenib. We've used it post-transplant in a number of our patients, but we need to wait for the final data to know that it will show the same degree of benefit, which we hope it will, that sorafenib has shown, or even more. So now what about relapsed refractory disease? So gilteritinib has shown survival benefit. I know you will have a talk on this later. This is a good benefit, but at the end of the day, when you look at the 2 year survival, it's less than 20%. Most of the patients are relapsing except those who go to stem cell transplant. So the question is, how can you improve on it? One of the efforts is, of course, to combine FLT3 inhibitor with other effective drugs in AML, one of them namely being venetoclax. This is data from Marina Konopleva showing venetoclax with quizartinib. Similar data has been generated from Tony Latai from Dana-Farber and the Ohio group looking at gilteritinib and sorafenib. All of these have shown very potent synergy from synthetic lethality. And what's interesting is that the FLT3 inhibitors also downregulate MCL1, which is actually upregulated in 80% of patients who become resistant to BCL2 inhibition with venetoclax. And so there may be a dual benefit of FLT3 inhibition here. It's, of course, downregulating, suppressing the FLT3 directly, but also maybe suppressing MCL1, which could help avoid resistance to venetoclax. And so this has led to clinical trials. This was published a couple of months ago in the JCO, combining venetoclax gilteritinib, as you can see, very encouraging response rates close to 75-80%. It did not matter if the patient had received prior FLT3 TKIs like sorafenib midostaurin, the response rate was the same. And this looks better, again, across different trials, but looks better than what's seen with Admiral. In fact, this population, if anything, was worse than Admiral. These were salvage 2 and 3, not salvage 1 like Admiral. And these patients, most of them had a prior TKI, about 65%, compared to 10% with prior Admiral study. Now, that being said, there is significant myelosuppression, so one has to be aware of that, and one has to be ready to reduce the venetoclax duration to 21-14 days. That is a common theme across the board, even with HMA venetoclax or pretty much any venetoclax combination. If done appropriately, the early mortality is not too high, 14%. In fact, with gilteritinib alone in Admiral, it was 13%. So this can be managed, but one again has to be aware of myelosuppression. The best way to use this regimen, in our experience, has been to use it to achieve a marrow remission clearance, often with molecular reduction or even clearance of the FLT3, and proceeding to allogenic stem cell transplant. That is where we have seen the patients achieve long-term survival. It is difficult to give this long-term without a transplant. We have some patients where we have given it for a couple of years, myself, Sasha Pearl, others, but in general, it is difficult to deliver this long-term. We usually have to bring the venetoclax down to 14 days, 10 days, or even lower, and the gilteritinib usually can continue. So very effective regimen. I would use this for my patients below 70, 72 who I'm trying to take the transplant over single agent gilteritinib. But for long term, sometimes we've had to use the doublet for a couple of cycles, 3, 4 cycles, achieve a good remission, sometimes get low or clearance of molecular, and then go with gilteritinib single agent. So that has to be also a potential option one will consider. Now, frontline aza-ven, very good. You have probably heard and seen this data many, many, many times. Published New England Journal, led by Dr. Courtney DiNardo. You see the survival here, 15 versus 10 months. That is good, but 2-year survival still coming close to around 30%, so not curative yet on its own. FLT3, unfortunately, is one of the difficult mutations with HMA-VEN, even though the remission rates are quite good, 65 to 70%. In the FLT3 ITD, especially, the survival with HMA-VEN was 11.5 versus 8.5 months. It's still better with HMA-VEN than HMA, but marginally. And so the question is, what can we do to make it potentially even better? TKD, interestingly, does quite well. CR/CRI rate was 77% with HMA-VEN, survival 20 months. So the TKD does not seem to predicate a resistance to the HMA-VEN. So the approach we have taken in clinical trials ongoing at Anderson at this time is to combine the 3 drugs. There are pros and cons to this, and I think it's important to look at sequential approaches. I know some trials are starting to look at that. In our experience, though, this combination has been very effective, with the 3-drug combination giving us high CRC rates, high flow MRD negativity, which is the most sensitive MRD we have at Anderson. Also PCR negativity, although our PCR is not as sensitive as our flow in our institution. And even the true CR rates were 67 versus 32%. So count recovery is occurring with the triplet. It just can take a little bit longer. So one has to be aware of and monitor for that. So count recovery, because this is something I get a lot of questions and emails and phone calls on. So this is the way to look at it. When you look at the triplet, the count recovery in responders is longer. But actually, when you look at all patients together and you draw a line on day 1 and day 42, the count recovery overall is better with the triplet because the CR rate is double. So when you look in day 42, you see that the ANC is greater than 0.5 in 52% of the people who are on our triplet versus 33% on the doublet. So even with the additional myelosuppression from the 3rd drug, the benefit of the response seems to be more important with good count recovery. Now, that being said, again, remember, we are using modified doses. So we're using venetoclax 14 days and the FLT3 inhibitor also now in cycle 1 for 14 days We do a bone marrow on day 14 for all patients. Once we confirm that there's no progressive disease, less than 5% blast, or hypocellular ablated marrow, we stop and we allow count recovery. Dr. Short will be presenting the update of the Azaven Guild at ASH and Dr. Yilmaz on the DACVEN quiz. What I can say is by day 14, we're seeing pretty much everybody has cleared the disease, almost 95%. And so I think 14 days is sufficient to achieve disease clearance. And then subsequent cycles, we often drop the ven down to 7, 10, or 7 days, continue the FLT3 inhibitor. And this seems to be running quite well. At this time, we will update the data, and hopefully with more numbers, we can be more definitive in what we're seeing. So what about MLL rearranged, different subgroup? This
Two
is a
minutes more.
very
Two,
different
2 minutes
subsets
more.
here, where we are looking at a population of MLL rearranged patients, and there's a group of drugs called menin inhibitors that has been developed here. These are the response rates. This will also be updated ASH. I think this is a major breakthrough for MLL rearrange, which historically do quite poorly. And again, as single agents, you get activity, but duration of response has been limited. So hopefully in combination, it will be better. Differentiation syndrome does occur, and that's something one has to be look out for, so be aware of that. And there are many menin inhibitors ongoing in clinical trials. Syndax and Cura are the most advanced, but there are others also that we will see data in the near future. And last, I'll talk quickly about TP53. This is, of course, the most difficult subset here. Immune approaches are what we hope will work here because targeted molecular therapies have not worked. HMA-VEN, here you see that the response rates again were not bad, 50 to 55%, but the survival was limited, 5 to 6 months in 3 different analyses of different HMA-VEN combos in TP53 mutated AML. We're hoping that the CD47 immune checkpoint pathway that activates macrophages could be a step forward here. This works by blocking CD47 SERP alpha interaction, unleashing macrophages to attack the tumor cells, and has been shown by Ravi Majeti in the group at Stanford to be especially important in the leukemia setting. Also, combining CD47 antibody with azacitidine seems to have a benefit by upregulating the eat me or prophagocytic signals like calreticulin and others through azacitidine, which is important in the setting of CD47 or don't eat me signal blockade. This is the data we showed at ASH. Here you see the response rates are about 49%, CR rate about 33%, a little better than what you see with HMA-VEN. The duration of response seems to be what could be better, about 9 months compared to about 4 to 5 months historically with HMA-VEN, 4 to 6 months with intensive chemo. Will this hold up? We have to wait and see in a phase 3 study that's ongoing. In general, this agent has been very well tolerated in our experience. The anemia does occur. This is seen in the first 8 to 10 days as an on-target effect from clearance of red cells. And with close monitoring and awareness, this has not been a problem in our center and other large academic centers. This did lead to an FDA hold that has now been taken off, but I think with the increased monitoring and awareness data, this should not be a big issue. Well, could you combine aza-ven and magrolimab? Preclinical data from Marina Konopleva suggests that the three-drug combo was better than either doublet, especially in TP53 PDX mouse models. And this is early data we have generated. I think that this could be an important regimen, both in TP53 wild type and mutated. We will be updating in this year's ASH. And of course, there's already a phase 3 study looking at both the combos, the aza-magro and the aza-ven-magro in frontline TP53 mutated and the aza-ven-magro in both TP53 mutated and wild type. So we have to wait for those data. And lastly, I think immunotherapies are very important outside of the antibodies. We have not had as success as has been seen with ALL, lymphoma, myeloma, but that does not mean that these will not work. We will have to be novel and innovative in our approaches. Buy or try specific CARs may be the way to go. The innate immune system seems to be important and more harnessable in the setting of AML, macrophages, NK cells, NK CARs. Especially, I am quite interested in the NK approaches. We have seen some very interesting and unexpected responses, especially in MRD low burden disease in high risk patients. With these, there are a number of NK approaches, Fate Therapeutics, Glycostem, and Carta that Gautam is working on with others. And I think the nice thing with NK is that we get almost no toxicity, no CRS, no ICANS, neurotoxicity, overall well tolerated, and can be given at very high volume and may be a good path in the low burden oligoblastic disease. I really think this is where immunotherapy should be developed. We're learning that from ALL myeloma. It works best in low burden disease. So you debulk with your optimum frontline therapy, whether it's intensive or lower intensity combinations, doublet, triplet, and then bring in the immune therapy to mop up residual MRD. I think this should be the paradigm, and finally, many of the trials are moving in this direction. So with that, I will stop. I think there's a lot of progress happening in AML. A lot of it already has come to fruition in the favorable groups, core binding factor, NPM1, FLT3 maybe, but hopefully in the near future, the menin inhibitors, CD47, APR, and cellular therapies, NK and CAR T, will start making more and more impact for the high risk patients going forward. So thank you very much.